general approach to what we plan to do is have a general approach to arrhythmias to know the differences between regular and irregular tachycardias, to diagnose narrow complex tachycardias, and to diagnose wide complex tachycardias. So my approach to arrhythmias, or to the patient who has an arrhythmia or who complains of palpitations, is number one, look at the patient. There is no substitute for looking at the patient directly. But in this context, what I mean is the patient hemodynamically stable? If not, then you may need to, and the patient has a tachycardia, you may need to cardiovert that patient regardless of what the rhythm is. Second, if not, then you have time to do a 12-lead ECG and try to make the diagnosis. Does the patient have structural heart disease? You know, for almost any arrhythmia, get an echocardiogram. Does the patient have valve disease? Does the patient have heart failure? What is his or her ejection fraction, which will impact what medicines you prescribe. Then look at the EKG. And we recommend, as proposed by Dr. Grauer, a systematic approach, excuse me. So there are 5 key parameters. Watch your P's and Q's and the 3 R's. So P, are there P waves? Or if not, are there signs of atrial activity such as fibrillatory waves or atrial flutter? That's P. Q, is the QRS wide? You know, if it's anything more than 120 milliseconds, that qualifies as a wide QRS. And then the 3 R's, what is the rate? What is the ventricular rate? What is the atrial rate? They may not be the same. What is the regularity? In other words, is this a regular rhythm or an irregular rhythm? And related, is there a specific relationship between QRS complexes and neighboring atrial activity? Then look for and treat precipitating or reversible factors like electrolyte imbalance, ischemia, drugs, hypoxemia, hyperthyroidism, and others, because treating or alleviating those conditions may treat the arrhythmia without specific drugs for the arrhythmia. Finally, treat the arrhythmia if necessary. Some arrhythmias is not necessary to treat, but others it is, with either drugs or devices or surgery. So starting off with narrow complex tachycardias, defined as rate over 100 beats per minute and QRS complex less than 120 milliseconds, 3 small boxes. Okay, so the regular tachycardias are sinus tachycardia and atrial tachycardia, AV nodal reentry, AV reentry, and atrial flutter. Irregular tachycardias are atrial fibrillation, which is by far the most common, atrial flutter, or multifocal atrial tachycardia, which is mostly in very sick people. If you have a regular narrow complex tachycardia, then you can see P waves, then what you look for is either a long RP interval or a short RP interval. So that's the distance between the QRS and the next P wave. All right, so this would be a long one. This would be an example of a short one. The long ones are sinus tachycardia and focal atrial tachycardias. The short ones are AV nodal reentrant tachycardia, where that little blip after the QS, RS, kind of an R prime. It's not really an R prime. It's really a P wave. It's a retrograde P wave, but we'll talk about that. Or possible retrograde P waves from an orthodromic reentrant tachycardia. So here's an example of sinus tachycardia. This is pretty fast, actually. It's 150, a little over 150. But you can see P waves clearly right in front of every QRS. And the P waves are sinus P waves. They're upright in 1, 2, 3, and AVF. So, right, the P wave axis is going from the upper left to the lower right. So it's traveling inferiorly, which is a sinus P wave. Some of the differences between sinus tachycardia and supraventricular tachycardias are the SVTs begin abruptly. You know, the rate is somewhere between 160 and 240, and they can be terminated by a vagal maneuver. Whereas sinus tachycardia begins more slowly, more gradually in response to a physiologic need. Usually the rate isn't over 160. Not that it's impossible, just usually isn't. And a vagal maneuver may not have any effect, or it may momentarily slow it down, but it won't convert it. So here is a 76-year-old man who's in the hospital for treatment of acute leukemia, who triggered for a high heart rate. Right? I mean, that expression is that there's the monitor recorded a high heart rate, and the nursing staff called the physician on call. And so here you have a narrow, complex, regular tachycardia. The rate is over 150, 160, possibly. Okay. And what you see P waves. All right. But the P waves are not sinus P waves, right? Because they're inverted in 2, 3, and AVF. And you can hardly see them in possibly that second little blip is a P wave in V1. But here you see it with a long RP interval. Okay. And so this is an atrial tachycardia with a long RP interval and a negative P wave because the atrium is being activated retrogradely from the source of this atrial tachycardia. And here he is the next day, back in sinus rhythm, and you can see that clearly his P waves are now sinus P waves. They're upright in 1, 2, 3, and AVF. Okay, so this is an atrial tachycardia. Now, I want to introduce the concept of reentry circuits, which is the pathogenesis of AV nodal reentrant tachycardia. So in the AV node, there are two pathways. There's a slow pathway and a fast pathway. Normally, the impulse travels to, approaches the AV node and goes down both pathways. Goes down the fast one quickly, down the slow one slowly. The slow pathway recovers faster. The fast pathway takes more time to recover. It transmits faster, but recovers more slowly. So what happens here is, by the time the impulse gets to here, this hasn't arrived yet, and so the impulse goes to the ventricles, and you have sinus rhythm, as noted here. If, however, there's a block in the fast pathway, then the impulse travels slowly down the slow pathway, and by the time it gets to this point, the fast pathway has now recovered, and therefore it travels retrogradely up the fast pathway, and then around and around, and that's called a reentry circuit. The British call it a circus movement, but I think a circus movement in the UK is like Piccadilly Circus. It's not like the circus with clowns. So, and here you see an example of the retrograde P waves that occur with a short RP interval. So it's going in a counterclockwise fashion, and the atria are depolarized retrogradely. And you can have this and have reentry in atrial flutter. You can have it around scars, both in the atrium. This shows it in the atrium, but it can also have it in the ventricle. So here's an AV nodal reentrant tachycardia, very rapid, narrow complex. And you see this so-called R prime in V1. So it's RS, and then this funny looking R prime. Okay. And then with the adenosine, that disappears. So I think you can see, not very well. There it is right there. There it is there. Can't really see it there. But there's a pause, and then this is a sinus beat, and a couple of other beats. So this is the sinus rhythm, and this is AV NRT. Now here is a regular tachycardia with wide complexes. Okay, a 37-year-old man who complained of palpitations, and these bizarre QRS complexes with a left bundle type appearance. Okay, and this man was given adenosine, and after he had adenosine, he went back into sinus rhythm. And what you can see is a wide QRS complex with the QRS complex encroaching on the P wave. So you have a short PR interval and a slurred upstroke called a delta wave. Good example here. Good example here. And this is a condition called Wolff-Parkinson-White syndrome. This was first described by doctors Wolff, Parkinson, and White in 1930, and bears their name. And so what's happening here is that is the following. There's the reason that Wolff-Parkinson-White syndrome is called pre-excitation. There is a bypass tract that bypasses the AV node. So if you have transmission down the bypass tract that's faster than the transmission down the AV node, you get the short PR interval and the delta wave. You can have two kinds of AV reentrant tachycardias. In an orthodromic AV reentrant tachycardia, the impulse travels down the AV node and back up the path, back up the bypass tract. Okay, giving you a narrow complex with a retrograde P wave and no delta waves. An antidromic AV reentrant tachycardia is in the opposite direction, travels down the bypass tract and back up the AV node, giving you no P waves that you can determine, but a wide tachycardia with delta waves, like on the patient that I just showed you. And here are doctors Wolff, Parkinson, and White. Dr. White is famous in the United States and around the world, actually. He's widely regarded as the founder of preventive cardiology, and he was one of the founders of the American Heart Association. He was an advocate for healthy living, promoting physical exercise, sleep, and a nutritious diet. And there are these bike paths along the Charles River in Boston. So this is the Charles River. This is Cambridge. This is downtown Boston. You can see, or no, this is actually the Back Bay, what's called the Back Bay of Boston. And this is the Charles River, and here are the bike paths on the Cambridge side and on the Boston side. And this is from their original paper. Very nice illustration, really, of the short PR interval and delta wave. Now, here is a 73-year-old man who complained of palpitations and lightheadedness. And this is a regular, narrow, complex tachycardia. And does it have P waves? The answer is yes. You can see them here in V1. There are probably 4 of them for every QRS, so there's a 4-to-1 AV conduction. And you see what are called sawtooth pattern in leads 2, 3, and AVF. So negative P waves in 2, 3, and AVF. Negative because the reentry circuit is traveling in a counterclockwise fashion. And so here he is, whoops. Here he is with 4-to-1 conduction and a ventricular rate of a little under 100. Here he is with 2-to-1 conduction, right? So you can see here's a P, 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 okay? And a heart rate of faster than 150, probably 170. Okay, and here you see what are called flutter waves. And this illustrates where they are. Okay, and here he is back in sinus rhythm. And you can see that this is sinus rhythm with sinus P waves. Now, here's a lady that came into our clinic complaining of a cough. And she had a cough, and the daughter thought she had, pneumonia or the flu or something and wanted an antibiotic. This is her electrocardiogram. What do you think this rhythm is? Put your answer in the chat. Takers? Well, it's a narrow, complex, irregular rhythm. And you can't really see P waves unless you want to count these things. Okay. Now, an irregular rhythm with a rate over 100, where you narrow complex, where you can't see P waves, you can guess that it's atrial fibrillation, and you'll be right almost all of the time. Almost all, 90% of the time, you'll be right. Atrial fibrillation is the commonest arrhythmia that we see. Practice, it's the commonest arrhythmia that the electrophysiologists see. It's the commonest arrhythmia in the hospital. So it's just extremely common. Okay, and here we go. Here's atrial fibrillation. And this is one of my favorite slides because it shows, it really depicts atrial fibrillation. So here, this is sinus rhythm, starts in the SA node, AV node, his Purkinje system, sinus rhythm right here, and then And with atrial fibrillation, there are upwards of 360 fibrillatory waves, little reentry waves in the atrium that bombard the AV node. There is variable penetration, and so there's variable refractoriness, and that's what makes the rate irregular, like this. For atrial fibrillation, we recommend a patient-centered integrated approach, treating the comorbidities and the risk factors, avoiding stroke and thromboembolism, anticoagulating these folks, either rate control or rhythm control to reduce symptoms, and evaluation and dynamic reassessment to follow the patient. So this is the care model of atrial fibrillation treatment. Now, there are a number of, it's not generally appreciated, but there are a number of comorbidities and risk factors in atrial fibrillation that, if you treat them or reduce them, you will improve the atrial fibrillation. So, for example, blood pressure lowering medication, treatment, effective glycemic control for diabetics, treatment for heart failure, treatment for obesity, aiming for weight loss or bariatric surgery, management of obstructive sleep apnea, reduction in alcohol intake to less than 3 drinks per week, increasing exercise. An exercise program can reduce the incidence of atrial fibrillation. So, encourage people to exercise, and then other risk factors and comorbidities as well. So here's a 64-year-old woman who complains of palpitations. She's got a very rapid but irregular, narrow complex rhythm. You cannot see P waves, so what do you think the diagnosis of the rhythm is? It's atrial fibrillation. It's kind of a no-brainer. This arrhythmia is most consistent with which endocrine disorder? Hypothyroidism, hyperthyroidism, hyperparathyroidism, Cushing's disease, or Addison's disease. Mahmoud and Mohammed got it right. It's hyperthyroidism. If you treat the hyperthyroidism, the atrial fibrillation may go away, and you can continue. You can discontinue anticoagulation in some of those folks. Why am I? Okay, now this is multifocal atrial tachycardia. And what you see here is, you can see that there is a clear baseline, and there are clear P waves of at least 3 configurations. So it's narrow complex, rate over 100, and at least 3 different P waves that are obvious and have 3 different configurations. So here's 1, here's number 2, this may be number 3. There's number 3 for sure. Okay, yeah, there are 2 of those, and then a couple of these, and then this one. So you can see the P waves. Now these are usually very sick people. They're in the ICU. They're on respirators. So it's a kind of a special population. you're not likely to see this sort of, patient with an ECG that looks like this walk into the clinic. Pretty unlikely. Now, this is the sick sinus syndrome, or tachycardia bradycardia. Okay, so here you have a rapid rhythm, narrow complex, irregular, no P waves. This is atrial fibrillation, which then converts with a 5-second pause. So that's why it's called sick sinus syndrome, because the sinus node is supposed to take over here. In order to treat this atrial fibrillation, you need a pacemaker in order to prevent this sort of thing. Now, here's a 68-year-old woman who complained of shortness of breath and palpitations for a week. She has a history of hypertension, of chronic kidney disease with a creatinine of 2.5, and coronary artery disease, for which she received a stent 2 years ago. Okay, and here's her ECG. What is this rhythm? At rapid, irregular, narrow, complex, rate over 100. This should be an easy one. No? Sinus rhythm? Really? Really? This is atrial fibrillation. It's not a great electrocardiogram because you don't see the marks, but still, I think you can tell that it's atrial fibrillation. So, she's anticoagulated, and then she's cardioverted to normal sinus rhythm, and she feels great. 6 months later, symptomatic atrial fibrillation recurs, and she is given sotalol, 80 milligrams twice a day, and converted again. She feels well again in sinus rhythm, but returns after 2 syncopal episodes. So this is her cardiogram. It's a regular rhythm with sinus P waves. So the sinus rhythm, what do you notice about this? What you should notice is that the QT interval is prolonged. The normal QT is less than half the RR. A prolonged QT is more than half the RR. And this QT starts here and goes almost all the way over to here. So this is a prolonged QT. In which case, what is the most likely cause of her syncope? What do you think the most likely cause of the syncope is? Right? Put your answer in the chat. Do I have any takers? All right, Abdul Rahman got it. It's torsade. Mahmoud got it also. It's torsade de pointe. Torsade de pointe means torsion of the points. And so here's what happens. You have some PVCs, and then they're repetitive, and then you have this torsion of the points from down to up to down in the same lead, because things get worse, much worse, and they deteriorate, and she winds up needing needing defibrillation, which she received, and so the question is, how would you treat her atrial fibrillation now? And with drugs or with ablation? The short answer to that question is with ablation. That's what would be needed. Okay. Now, there are a number of risk factors for drug-induced torsade, which is what we're talking about. There is congenital long QT syndrome, but that's much less common than drug-induced torsade. If the QTC is prolonged greater than 500 milliseconds, if your patient is on a QT prolonging drug, especially if he or she is on more than one QT prolonging drug. And then what I call the three hypos: hypokalemia, hypomagnesemia, hypocalcemia. Diuretics, because they cause hypokalemia and hypomagnesemia, heart disease, and bradycardia of almost any cause. Okay, here's a very short list of drugs which can pose a risk of torsade. The full list is a page and a half, single-spaced. So there's a really very long list of drugs which cause torsade de pointes. Okay, but they're, the common ones are arrhythmic drugs, anti-arrhythmic drugs like sotalol or dofetilide, antibiotics like levofloxacin, ciprofloxacin, azithromycin. The antifungals can do it. Antidepressants or antipsychotics, and then a number of others sort of in this catch basin, if you want to call it that. So there are a number of drugs that can cause QT prolongation, and you really need to be careful about that sort of thing. Now, turning to, that's my segue to ventricular arrhythmias. So looking at ECG characteristics of funny-looking beats. Are they PVCs or PACs with aberration? Are they truly ventricular? Wide complex tachycardias, is it ventricular tachycardia or supraventricular tachycardia with abnormal conduction? And then the terminology is VT is more than 3 PVCs in a row, but less than 30 minutes. It's called sustained VT if it's more than 30 minutes, 30 seconds, excuse me, in duration. And then there's monomorphic versus polymorphic. Torsade de pointe is polymorphic VT, ventricular tachycardia. So here are examples. Here's a ventricular couplet. Here are 4, so that counts as ventricular tachycardia. Here's bigeminy, meaning every other one, and here's another. Here's trigeminy, which is every third. You can tell if PVCs are more dangerous if the R interval is very short, so that the PVC is encroaching on the T wave. See, and the issue with prolonged QT is just that. You see, with a prolonged QT, you have much more time for the PVC to land in the vulnerable period, as you see here. Okay. These are some of the things that premature atrial complexes can do. They're either not conducted, conducted with conducted normally or conducted with a right bundle branch block configuration. And so we can talk about the Eshman phenomenon. The Eshman phenomenon is aberrant ventricular conduction due to refractoriness of the right bundle. So if you consider that this is the QRS and this is the QT interval or the refractory period, then the right bundle is longer than the left bundle. And so a PVC or a atrial premature that lands here isn't conducted at all. One that lands here is conducted normally, and one that lands here is conducted with a right bundle configuration. And it's the QTC is inversely proportional to heart rate. So at faster heart rates, the QT is shorter. At slower heart rates, it's longer. And what happens after a pause is that this beat has a longer refractory period, and therefore the next beat here is has a right bundle configuration. So that's the Eshman phenomenon. Okay, now considering wide complex tachycardias, the differential diagnosis is very important. And Dr. Peter Zimmerbaum, who is the Assistant Chief of Cardiology at Beth Israel Deaconess Medical Center in Boston, where I practiced, it gives this way of approaching the problem as printed and up to date. So, if a patient is unstable, treat them as if the rhythm is VT until proven otherwise. Okay, patient is unstable, treat it like VT. If stable patients, look and see if the rhythm is regular or not regular. If it's regular, it's most likely to be monomorphic VT in 80% of people. If it's irregular, over 90% of them have AFib. But polymorphic VT might also be irregular. What is the QRS axis? So a right superior axis, this so-called northwest axis, strongly suggests ventricular tachycardia. Is there AV dissociation? That is, look for fusion and capture beats. And is there a history of a heart disease or arrhythmias? Because VT is likely with a wide complex tachycardia in people over the age of 35 who have coronary artery disease. So it's most likely ventricular tachycardia. Okay, now this shows fusion beats and capture beats. So in ventricular tachycardia, what happens is when the impulse comes from the sinus node and gets to the AV node, because of the more rapid ventricular rate, the AV node is refractory, unless it lands at just exactly the right time, like this, in which case it will conduct and cause a narrow complex beat, which is called a capture beat, in the presence of a wide complex tachycardia. Okay, and then sometimes you have fusion beats, which are the meeting of two impulses in the same chamber. Again, a function of AV dissociation. Okay, now what we generally suggest is to use the Brugada algorithm. Okay, so if there is an RS present in the precordial, any of the precordial leads, then you go to the next thing. If it's not present, it's VT. No question. Okay, if it is present, you look for the R to S interval of greater than 100 milliseconds. If that's not the case, look for AV dissociation. If you find AV dissociation, that's VT. If you don't, look at the morphology. And so we can look at morphology in a number of settings. Here is a typical. Okay, so look in lead V1. The RSR prime, the rabbit ears, RSR prime favors aberration as opposed to ventricular tachycardia. Whereas a narrow an R wave that looks like that or like that in V1 suggests VT. If you look in V6, okay, look in V6 and you see a complex that looks like that, that's VT. Here. Okay, that's VT. And then for left bundle branch block configurations, narrow complex, narrow R wave, skinny R wave with a prompt downstroke suggests aberration, and whereas a wide R wave and a slurring on the downstroke suggests ventricular tachycardia. And you can play the odds, right? If you have a clinically stable wide complex tachycardia and it's regular, up to 80% are ventricular tachycardia. If it's irregular, 90% of them are AFib. Either AFib with a bundle branch block that was present before, a person who happens to have a bundle branch block anyway, who then gets atrial fibrillation, will have a wide complex tachycardia, right? With the same bundle that they had before. Or atrial fibrillation with WPW, which is fast, bizarre, and highly irregular, more likely in young or otherwise healthy individuals. Okay, and so the common causes of monomorphic regular wide complex tachycardia of uncertain etiology are ventricular tachycardia is number one. Numbers 2, 3, 4, 5, 6, 7, and 8 are all ventricular tachycardia. Number 9, in terms of prevalence, is SVT with a pre-existing bundle, and 10 SVT with aberrancy. So here is a ventricular tachycardia with fusion and capture beats. The P waves are marked off here in red, and then this is the fusion beat. And this is a capture beat, this beat. Okay, so here is a 53-year-old woman with non-ischemic cardiomyopathy who has a rapid heart rate of over 150, wide complex tachycardia. Is this VT or SVT? VT or SVT? Mahmoud, you're right. It's VT. If you go by the Brugada algorithm, you see there are only R waves, no S waves. So that's it. That's VT. But there are some clues here. There are P waves marked off here, and the timing is here. So the sinus rate turns out to be 71 beats per minute, and the ventricular rate turns out to be probably 130 or 40 beats per minute. So this is a ventricular tachycardia in a patient with non-ischemic cardiomyopathy. Here's an 85-year-old woman with severe aortic stenosis who presented with syncope. And here is her rhythm. It's got a right bundle branch block configuration. Is it regular or not regular? The short answer to the question is it's not regular. You notice? This is not regular. What is this? This is atrial fibrillation in a person who happened to have a right bundle. Okay, here's her previous tracing, and here's her right bundle right here. And here she is when she gets atrial fibrillation. Still got the right bundle. Okay, here's a 25-year-old man who complained of lightheadedness for 2 hours, and he has a highly irregular, wide complex tachycardia. What do you think this is? Was the previous slide M shape? Oh, Sonia thinks it's VT. Well, not so much, Sonia. This is highly irregular, wide complex, highly irregular. It's not polymorphic VT. It's atrial fibrillation with WPW. Okay, so here's atrial fibrillation in WPW. You see here all the atrial impulses all traveling down the bypass tract. So there's rapid conduction. Okay, and here's the risk of atrial fibrillation in WPW because it can deteriorate to ventricular fibrillation. So this person should have, he should be cardioverted back to normal rhythm with this, and then he should go right to the electrophysiology laboratory and have his bypass tract ablated because of this danger. Okay, and here, I think finally, here is a 67-year-old man with a slow rhythm, relatively slow, but it's not a sinus rhythm. There are sinus beats, but it's not really a sinus rhythm. And so, what do you see here? You see a P wave that's not really conducted. That's not really conducted. This one is conducted. This one is not. This one is not. And then you lose the P waves, and then they come out on the other side, and here's conduction again. This is accelerated idioventricular rhythm. It's a ventricular rhythm. It's like ventricular tachycardia, but it's not. Doesn't behave like ventricular tachycardia because the rate is slow and really no treatment is needed. So but it's a ventricular rhythm with AV dissociation. So with that, here's again my approach to arrhythmias. Look at the patient. Look at the EKG, look for and treat precipitating or reversible factors. Treat the arrhythmia if necessary. In the case of atrial fibrillation, prevent thromboembolism and no